All right. Okay, let's get started. So we are so excited to have Dr. Philip Chen, who is a current professor in otolaryngology, head and neck surgery at the University of Texas Health San Antonio, and also an adjunct professor in the Division of Otolaryngology, Head and Neck Surgery, also at the Uniformed Services University of Health Sciences. He has lectured internationally and authored multiple publications as well as book chapters. He is interested in resident education, cerebrospinal fluid leak, and anesthesia for sinus surgery, as well as surgical ergonomics. So please give it up for Dr. Chen.
I'll say good afternoon, because where I am in Texas, it's now 1:30 in the afternoon, and I just had lunch. So I hope everybody is more awake than I'm feeling right now. But I'm going to enjoy talking to y'all. And I really give everybody credit for being here on a Sunday, whether it's morning or afternoon or wherever you may be. And I think that in many ways demonstrates your dedication to the field of medicine. And also it's something you're going to have to get really used to, unfortunately, because people always get sick. So whether you're a nurse, whether you're a vet, whether you're a doctor, there are going to be weekends that you're going to be working. And I think that's a privilege, but at the same time, it's something that we all have to know about as we get into it. So thank you, Ting, for that introduction. And I've been here in San Antonio now for a little over 10 years, really enjoyed my time here, a lot of opportunities in order to be part of this university. But like so many of you who are just getting started on this, I've gone through quite a bit of schooling, and it's been a fairly long journey as well. I went to undergraduate at the University of Pennsylvania. And for those of you who are earlier in your education, I wanted to make the point that actually I studied communications and commerce. And so while I did all the pre-med prerequisites, I really had an opportunity to learn other things that have been actually very useful in my career. And I can allude to that a little bit later, but one of the new roles I'm taking actually has a lot to do with what I learned back in college, which at this point is about 20 years ago. I went to medical school in Ohio at Case Western Reserve University in Cleveland. And then after that, did 5 years of training and residency in otolaryngology, also known as ENT, ear, nose, and throat. And then afterwards, I decided that since I never had an opportunity to study abroad in college, and also there's a wonderful fellowship, which is additional training after your 5 years of ENT training in sinus and skull-based surgery. So I took that opportunity to go to Australia, where I spent a fantastic year there learning about Australia and learning just more about the nose and sinuses than I ever could have imagined. So yeah, a lot of different places that I've been, and your education will likely take you to a lot of different places too. I think what's really, really important is that none of us can succeed in silos. That's something that I regularly say. This is a picture of me 20 odd years ago. And that's my mentor on the right, who unfortunately passed away suddenly 2 years ago of a heart issue that he didn't know existed. But this is a person who really invested in me, not only in my education and my career, but also invested into me as a person. And so I encourage all of you to find those people in your lives that are going to help you and support you and be, cheerleaders for you when things are going tough and when they don't seem like things are going the way you wanted. There'll be people that have been there before and who believe in you. And for Dr. Wong, he's just been such a huge mentor and friend to me, and I miss him dearly. So why did I become a doctor? As I mentioned earlier, I studied communications in college, but there are a lot of reasons why I was interested in a doctor, and especially in an academic career. And the first of all is that I really enjoyed science. I have a daughter in kindergarten right now. When she came home the other day and was telling me about understanding how tornadoes worked, I thought that was just fantastic because I love science, whether it's natural sciences or human sciences or biology. And so for that part, that's the part of it that always came easy for me. I wanted a job where I was able to help people. And so that doesn't matter whether you're a firefighter or a police officer or a teacher or whatnot. But for me, because I loved science so much, medicine made a lot of sense. I also really enjoy using my hands. I enjoy fixing things, even around the house. If something's leaking a faucet, I try not to call someone. I love using my own hands to fix it. So that's why surgery really made sense to me. And academia, I love teaching. I showed you a picture of Dr. Wong, who was such a great mentor to me. And hopefully I'm able to be even half the mentor to my medical students and my residents that he was to me. I hope I can continue to do that. To teach them is very fulfilling and rewarding. And I'm curious about things. And it's really cool. I just had a visiting professor come to see us here in San Antonio. I've not seen him for over 10 years, but he wrote a letter for me for my residency many, many years ago. And he mentioned that I was one of the most curious medical students he had seen. And so that curiosity keeps me interested in the field of medicine, but in my case, as an academic and research as well. So ear, nose, and throat, what is it? That's basically what we deal with. And for ears, there's a lot of different things that you can take care of. It could be ear infections, hearing loss. You can have tumors in the ear, believe it or not. And a lot of patients also suffer with dizziness. So in these pictures, you see a normal eardrum at the top. You see the bulging eardrum with the infection behind it, that white, probably some pus or mucus behind that eardrum. And then you see the air bubbles and the fluid in yet another eardrum. So those are just some examples of things you may see in the office. Now, for those of you who choose to do family medicine and pediatrics, internal medicine, these are pictures that you'll see as well when you look at your patients. Similarly, we can go from the ears and then go to the throat. Lots of different pathologies and conditions that people may discuss, whether they're having trouble with their voice. For those of you who follow music, many years ago, Adele, a very famous singer, had trouble with her voice, and it was a laryngologist that helped her. For those of you who might like classic rock, Steven Tyler recently had problems with his voice, so he had a laryngologist. And pretty much all of your favorite singers and vocalists and actors, see a laryngologist to help with their voice issues. Some people have swallowing problems. Sometimes after a stroke, for example, you may have some swallowing issues. Other people have other types of pathologies that lead to swallowing troubles. You can have tumors or cancers in the voice box. Here's an example of a little what we call granuloma in the voice box. This person's had a lot of scarring in their voice box. This does not look normal. And then also in ENT, we do have some emergencies. And so, for example, if a person can't breathe because something's stuck in their throat, or if there's a tumor that's blocking their airway, they can't breathe. And so, of course, we are the ones who put in the emergency airways, a tracheostomy, so these people can breathe. So you can see it runs the gamut from something like hoarseness, which is relatively benign. It's not going to hurt anybody, but they need their voice, whether they're speakers or whether they're singers or actors or teachers or whatever it may be, to things like emergency airways where literally seconds count so we can save someone's life. We can take out tumors in the head and neck area. So for example, thyroid tumors, as you can see in this picture on the far left, or this picture right here, or the parotid gland, which is a spit gland here on the side of the face or the ear. You can have benign tumors, you can have cancerous tumors, but a lot of different types of things of that nature. And then on the far right, that tongue, that's not normal. And you can see how irritated it is. You can see that white flakiness. This is an oral cavity cancer. And so again, things benign, oftentimes the thyroids are benign, oftentimes the parotid glands are benign, but it can be something serious like the cancer that you see here as well. So once again, there's a wide variety of things we do in ear, nose, and throat. A lot of people don't think about facial plastic surgery as something that we do in our field as well, but it is something that we commonly do. And if you think about it, if you're having something done on your face, who better to do it than somebody who deals with the face and the neck all the time? So most ENTs who do facial plastics aren't doing liposuction. They're not typically doing tummy tucks or other types of plastics. They're focusing just on the head and neck region. And that can be anything from like a facelift or a brow lift, rhinoplasty. Now, there's two types of rhinoplasty. You can have what's called a functional rhinoplasty, which is actually you're just helping someone to breathe better. But when you open up their airways, you don't want them to look bad, right? You still want them to look reasonable. So you help them with that. And then cosmetic rhinoplasties as well. I believe that gentleman who was on that Hollywood show, he was an ENT when he did all those rhinoplasty things. We take care of skin cancers. As you can see here, this woman at the bottom with this big defect in her cheek and her nose. Look at that skin cancer that was taken out, whether it's a basal cell or whether it's a melanoma, but look at how you can repair that. It looks very, very good afterwards. I would argue a lot of people wouldn't even notice. A little bit of makeup, you'll never even see it. So that's the beauty of this, is it's not only about trying to make people look a certain way, trying to look like Brad Pitt or something of that nature, but also to help people just look normal. In this case, you can see what a beautiful job that doctor did in repairing that. So I told you that I spent the extra year in Australia doing a fellowship. So that's after you finish your residency training, you go to do subspecialty training. And in my case, I am a sinus surgeon. And there's a story where a few years ago, my niece was joining me, was visiting us here in Texas and asking what we did. And I told her that I picked boogers for a living. And she went home and told her teacher that. When her teacher said, "Oh, what do your aunt and uncle do?" She said, "Oh, my uncle picks boogers." And the teacher did not understand what she was talking about. But in many ways, I kind of do as a joke because I deal with the nose and the sinuses. So when it comes to the nose, whether it's sinusitis, allergies, runny nose, people that have trouble breathing because their nose is blocked, whether it's a deviated septum or God forbid, something worse like a tumor inside their nose. People that have facial pressure, those are all things that I take care of as well that, in my realm. And so I joke that my little world is about this big. It's just about 2 by 2 inches. And there's a lot of things that go on in that area. So for us that do ENT, ear, nose, and throat, we're only working from here to here. We're not doing brains. We're not doing spine surgery. But nonetheless, there's a lot of anatomy and there's a lot that we do, and it's highly variable. And I think that's what's so nice about my field of ENT is that there's such a wide variety of organ systems that we work with. And these are the organ systems that interact with the world, right? You're seeing this video today. We don't do eyes anymore. Once upon a time, it was eyes, ear, nose, and throat. But, still, you're hearing this. I'm using my voice to speak to you. We smell foods. The way we interact with our worlds, a lot of that's in the ear, nose, and throat region. So that's what's wonderful about my field. I tell my residents and my trainees that I'm a radiologist as well. And I look at a lot of pictures, a lot of CT scans, X-rays, MRIs, because that's what helps me to diagnose what I do. And so this is an example of a CT scan. And I show all of my patients their CT scan so they have an idea of what's going on, so that they understand what I'm looking at when I tell them, what their issues are, what their problems may be. So here's an example of something we see down here in South Texas. For those of you who are in Florida, Georgia, Mississippi, Alabama, you might see this similar situation called allergic fungal sinusitis. And you can see, unlike the last CT scan where everything was nice and black and aerated, now these CT scans have all this junk in here, all this gray stuff filling in the sinuses. White as bone on a CT, and you can see the bone over the eyes has been completely eroded away. This is not cancer. This is not actually invasive. It's just fungus that is inside someone's nose. And you can see what that fungus looks like, this nasty brown stuff. And a lot of what I do here in South Texas has to do with this type of fungus. So I'll show you what that kind of looks like. So these are polyps right here in the left nasal cavity. This is the septum on the left side of the screen. And I'll show you what it's like. This is a little instrument that I had to take out these polyps. And you can see it's very gratifying to take these out, and patients feel so much better within minutes of taking it out. Now, this patient's under general anesthesia, so they don't feel any of this. They're asleep. The surgery probably takes about an hour on each side. So about 2 hours of general anesthesia and surgery for this person. But I'm taking out these polyps. This tissue is all swollen. You can see this nasty, nasty fungus that I'm getting out. This is not invasive. This is not an infection. This is the body's reaction to the fungus. And then the body has a severe inflammation, almost like an asthma type of situation, but this is just of the sinuses. And so I need to take all this material out. Otherwise, their symptoms are going to come back really, really fast. And so you can see it's very meticulous. Behind us is the straight back is the brain. Up to our left is the eyeball and the optic nerve. So it's a very, very narrow area. Right in the middle, that's the pituitary gland behind this bone, right in the middle. So it's a lot of very, very important anatomy around us. And we need to get all of this fungus out without damaging anything around it. Carotid artery is running in this little crevice right here on the left-hand side as well. So a lot of anatomy, and that's what it's all about being a surgeon. It's all about anatomy, knowing where you are, knowing where you're going, knowing what's safe and knowing what's not safe. But it's very rewarding. It's great to be able to help patients to feel better. Here's an example of a cerebrospinal fluid leak. What is cerebrospinal fluid? Well, it's fluid that surrounds our brain, and that fluid helps keep our brain clean. It regenerates kind of like a water filter does in a pool, and it keeps any bacteria, viruses, and whatnot out of the central nervous system. At the same time, it gives our brain some buoyancy. The brain actually floats within this fluid inside the skull. But interestingly enough, the bone between the nose and the brain is super, super thin. And so sometimes if someone's in a motor vehicle accident, or if they have a long history of obesity or high blood pressure, the little bone between the nose and the brain can actually erode. And it doesn't take very much of a hole in order for fluid from the brain to leak down into your nose. It's kind of like if you try to hold water in your hand, you can't really do it, even though when you look through your fingers, you don't see any light. It takes a very, very small hole. So you can see in this particular picture, this guy has this clear fluid, looks like water coming out of his nose. You can see how much of it is in this little kidney basin right here. And that's telltale for CSF leak. It's usually on one side. You may have a watery or metallic taste, and the patients often complain of a headaches. You always want to ask the patient if they've had trauma, like a motor vehicle accident or fell from a ladder. And also, very, very important, if they've had a history of meningitis, which is an inflammation and infection of the meninges that surrounds the brain. That can be a life-threatening situation. And so if there's a hole between the nose, which is very dirty, and the brain, which is very clean, you can see how bacteria and pathogens can go from the nose up until the brain. That's very, very dangerous. So we want to repair these. We don't want to leave them unrepaired. So here's a little animation that I did with a surgeon out in Virginia. He helped me do the animation, but these are my pictures.
The nose and the sinuses normally are completely separate from the brain. However,
and I don't need him to narrate. I can narrate, but you can see here, you get the frontal sinuses at the top. You can see your maxillary sinus has nothing to do with CSF leak. Ethmoid sinus is right here. And then I showed you, this is where I was working earlier, where I was getting that fungus out. And you can see the brain is up at the very, very top of this. And so as we go into the nose, because I do most of the things I do with a small little endoscope, so little tiny cameras allow us to look in the nose. You can see there's a defect right here where the arrow is. And so that's where the cerebral spinal fluid is coming through from the brain down into the nose. And so I want to patch it up with that little yellowness that you see there. So here's a real surgical image using that little endoscope. So not a microscope, but an endoscope. And you can see that yellow dye up there. I put some dye into the patient's spinal fluid, into their back, so that I can find the area that's leaking. And you can see that right there. So then I want to further define where this leak is coming from. So I elevate the tissue around it. And that allows me to find where the actual hole is within that, between the nose and the brain. You can see that clear, well, it was clear, but now it's yellow, that fluorescent yellow dye coming out. And that tells me exactly where that leak is. So now I take a little bit of fat in this particular situation. It's from the ear. It's very cosmetic. It's not a bite out of the ear, but it's taking a little bit of fat from the earlobe. People can't even see it. You can still wear earrings. And I gently tease that up into that hole. So this is called a bath plug technique, because it's just like a plug that you put into the bathtub to prevent the water from going down the drain. Same thing here. We don't want the cerebral spinal fluid coming through that hole. And so we plug it with some of the body's own fat, as you can see. And then we pull that string like you would pull a bath plug. And you can see that there's no more yellow fluid. It's completely stopped. And that's really, really important that it's completely stopped. We take a little bit of the body's own tissue. Then again, we cover up that hole with the lining of the nose so that they can heal real well, and it seals so that there's no more leaks. So we use multiple layers to give it extra strength. You don't want to just do one layer. You can see here I've got multiple layers, and then I cover it with a little bit more material so it scars in. And then we put a little bit of glue on top of it to further seal it. So you can see what an effort we make to make sure it's completely sealed. And that's how that works there. And we have a 90+% success rate on this surgery without any more leaking after this. So it works very, very well. You don't have to cut them open from the top like they used to have to do. These people can get out of the hospital in just a few days. They don't have very much pain at all. And so it's a really nice way to do things. And that's the beauty of medicine, is that we're always trying to advance. We're always trying to make things a little bit better for the patients and make the recoveries easier. Here's an example of a large tumor. This is a cancer that we took out, and you can see the defect that's left behind. So this is the basilar artery here. This is the brain up here. So that, just like the CSF fluid, when we were showing you that, this is a much bigger hole that's going to be much harder to repair, but you can see the main arteries that give the brain blood right here and here. And we took out this big tumor right here. So all done through the nose. and don't have to cut people open. It's amazing. I always tell them, you look no different after this 10-hour surgery than you looked before. No one's even going to know you had surgery, even though this is a huge surgery with a fair bit of risk. And so in this case, with a large hole like that, we can use the body's own tissue. And so in this particular case, I'm going to use the septal tissue, as you can see right here. You've heard of septoplasties. That's when we straighten out the crooked septum. But in this particular case, we can use the body's own tissue, as demonstrated right here, and use it as a covering. And the beauty of this covering is that you maintain the blood supply to the covering, because if the blood supply goes away, that tissue is going to die, right? All tissue survives off of blood. And so by maintaining this tissue attached back here, right where these instruments are, we're going to maintain the blood supply to the tissue. That's the picture that we showed earlier. That's the brain pulsing above you right there. Okay. And we cover up this hole between the nose and the brain with this piece of tissue. Having two surgeons really helps. So I'll work with my neurosurgeon to do this. And then you can see that pulsating brain at the top. We want to cover that up. So we take this tissue from the septum and we cover up that hole so that this patient does not have a cerebral spinal fluid leak. So bacteria from the nose can't run up into the brain and cause infections and other problems. So this is a great way to give the patient a nice repair. It's very strong. It's the patient's own tissue. There's no foreign materials used in some of these circumstances. There are some foreign materials we can use if necessary, but we don't have to. We can use their own body parts a lot of time, and that's what we did here. The other thing about being a surgeon that's great is that we can go around the world to help people around the world, whether it's mission trips. This is me as a resident in Bolivia. This is a large tumor that we took out. I mean, look at that. That's like it's bigger than a softball. And that poor lady had to deal with it for a really long time. And we were able to get that out for her. I told you I did my fellowship in Australia. When I was in Australia, we also went to New Zealand. So in the bottom right, that was our trip to New Zealand when we went to take out tumors in New Zealand as well. So there's a lot of opportunities for you as a surgeon to do good work, not only in your hometown, but wherever you may want to travel, because we need surgeons everywhere. What does it take to be a good doctor and really to be a good healthcare provider? I know not all of you want to be doctors. Some want to be nurses or vets or whatnot, and those are all great. But no matter what, there's no difference here. You have to have commitment to medicine, to your craft. You are never going to know everything you want to know, and you're never going to be perfect. You always have to keep learning. The minute you stop learning is the day that you should quit and you should retire. As we say for surgeons, that's the day you should hang up your scalpel. And it doesn't matter if you're a nurse or a lab tech or radiology tech, you have to keep learning because technology doesn't stay in one place. It's always moving forward. You have to have discipline. This is years and years of doing what we do. It is a long road. I'm not going to kid you. There were times that you're going to be kind of disgruntled. You're going to be tired. You're going to be discouraged. And that's when it's so important to have a group around you, whether it's friends, family, mentors, teachers, pastors, whomever, that are going to help keep you grounded and help keep you going, because the hard work never ends. Here I am on a Sunday lecturing to y'all because I do love teaching and I do love helping people. But you're going to be doing that regularly. You're going to miss weddings, you're going to miss births, you're going to miss birthday parties and vacations. And unfortunately, that comes with the territory. But you also have the most amazing opportunity to help people around you that no one else has. You're going to have your hand be the one that helps that patient to get over their situation, or the nurse that gives that patient comfort in their times of need, or whatever it may be. But you have to understand that you are going to sacrifice for that. You got to love science, because all of this is science, and you have to have a passion for making lives better. Your moral compass has to point in the right direction. People are not going to be looking over your shoulder every minute that you're working. So if you're a doctor, no one's watching you in the operating room to make sure you're doing the right thing, to make sure you're not doing more than you should be doing, to make sure that you're doing the surgery as well as you possibly could. No one's going to know because it's just you. If you're the nurse on the ward, nobody's following you around the wards to make sure you're checking every single thing twice and make sure that you are taking care of this patient like you would take care of your own family member. So your drive and your morals and your ethics have to be within you. It doesn't come from laws. It doesn't come from rules. It has to be within you. My curiosity has allowed me to do a lot of research. I don't get paid for my research. This is all done on nights and weekends, time that I donate to my medical students and my residents and to those who want to better themselves, because I know I'm always trying to better myself. And so through my desire to move medicine forward, I've done all kinds of research, whether it's on how to teach anatomy better. That's what we say. You see this frontal sinus masterclass and 3D conceptualization. We were able to take these ideas and actually turn it into actual software that you see in this picture that you can actually use in the operating room. So it's really cool to see people using my ideas to actually perform surgery and hopefully perform them better. I showed you all some CSF leaks. And so I wanted to do some studies on how to best repair that. So I was able to work with an engineer to create these pictures you see on the right, where we created a model in a lab to be able to test various types of repairs. And then, of course, antibiotics. We know that we use way too many antibiotics these days. We don't use them correctly. And so I wanted to learn more about antibiotics and allergies. And so I worked on this project here at the bottom. I will proudly say I did this with my wife, who's an anesthesiologist. And so, you can make this a family event or things that you do with your friends. It's great. It's a great opportunity to move medicine forward while continuing to build relationships. And then, of course, ergonomics. As a surgeon, we have a lot of problems with body aches and pains and whatnot. And so I encourage everybody, if you're not exercising, I don't like exercise, but you got to find a way to take care of yourself mentally, spiritually, and physically. And so I did yoga this morning. I did yoga on Friday. I don't like yoga necessarily, but it's really important that I keep taking care of myself. And that's why I started studying surgical ergonomics. So you find your passion and that's what you run with, right? And that's what I love about academic medicine is it allows me to mentor people, mentor these students, mentor these residents, at the same time do research. At the same time, some of these authors are people that I've become good friends with, people that I've gotten to know better through that. And you develop these friendships. So, this is me all over the world, frankly, Japan, Chile, went to concerts with my neurosurgeon, went to see Guns N' Roses there. This is the big picture in the middle is Las Vegas. I run a course in Las Vegas and I had 11 of my former residents, come to the meeting, which was awesome. These are all my former trainees. This is Philadelphia. We had dinner together. This is my mentor from Australia here in this bottom picture. This is my friend in Montreal in his lake house. I love baseball, so it was me taking my residents to a baseball game. So it's a lot of fun. You start building these friendships through academics and through research and through these meetings that are not just about teaching and learning, but about building human relationships as well. So that's my time, my friends. I thank you for this opportunity to speak with you. I'm more than happy for you to contact me. Here's my email. You can contact me anytime. This is the Alamo, one of the most famous sites in Texas and just down the street from me here in San Antonio. So congratulations to all of you. I hope this was helpful to you. And if I can be of any benefit, please don't hesitate to reach out.
Awesome. Thank you so much, Dr. Chen, especially showing the videos and the animation. I think that really showed it in real life, what it will look like. So to start off, one of the questions we had is during the presentation, you talked about working on skin procedures as well. So what would make a patient choose whether to go to an ENT or a dermatologist or a plastic surgeon for procedures related to those, since there is a level of similarity?
Yeah, absolutely. That's a great question. And the fact is there is a lot of overlap amongst Mohs surgeons who are surgeons who take out skin cancers. Some of them do reconstructions as well. Some of them have a relationship with a facial plastic surgeon or a plastic surgeon who do the repairs for them. A lot of times just has to do with how the patient, found out about that particular doctor. So if you wanted to have a whole body makeover, are you going to have an ENT do this part and then another surgeon do the rest, or are you going to have someone that does all of it? that's patient preference. And so a lot of it is word of mouth in the world of plastic surgery. It's, well, my neighbor or my friend or my relative had Dr. Blank do it. And so they go there as well. But I'm biased, but as an ear, nose, and throat doctor myself, I think facial plastics makes the most sense to take care of anything from the neck up. But again, there will be a dramatic disagreement from others who are plastic surgeons who still work in this area. I don't want to take away from them. Some of them are fantastic, but that's just my bias.
No, thank you. And then you talked about doing your fellowship in Australia. So we were wondering, when you did come back to the US, did you have to redo any training or get certifications since you did
Yeah.
it abroad?
That's a good question. So in my case, fellowship, there is no board for rhinology, sinus surgery. There's no board for that. So as a result, it didn't matter where in the world I did my training. I would highly recommend that you find good mentors who can tell you what kind of training makes sense. So for example, if I want to be a pediatric ENT, so do only, children and whatnot, 18 years old and younger, to be board certified in the United States in pediatric otolaryngology, you have to do a fellowship that makes you board eligible. So not all fellowships will do that. So for example, if I go to Australia, I would have to make sure that the fellowship in Australia was part of the American boards, and most are not. Some are, but most are not. So you're going to want to be careful with that. And I would say with those who want to go to medical school, something no one ever told me, and I didn't even know until much later, is that all medical schools are good. They're all going to give you really good education, but it is helpful actually to go to a medical school that has residencies in all the subspecialties. Even if you don't want to go there, you don't know what you're going to do in 4 years, right? And so, for example, for ENT, what I do, there are probably about 100 odd medical schools that have an ENT residency program. There are other great medical schools that don't have an otolaryngology program. And it's not the end of the world if that's where you are, but when it comes time to apply for otolaryngology residency, it's nice that, oh, I called, Dr. Smith, I know her well. We trained together, or we did a project together. I called Dr. Jones. She and I were on some committee together. We know each other pretty well because it's a small field. Same as in orthopedics, same in neurosurgery. So going to a medical school that has all of those is helpful, even though because you don't know what you're going to do in 4 years. And that's not to take away from the other medical schools that don't have them. They're still great schools. You're still going to learn well. You're still going to be board eligible. It's just, some of those opportunities may be harder to find. Like if you want to do research, for example.
Right. And thank you. That was really good advice. I think we could take it to heart when we're considering applying for medical school. Also about ENT. So I know you talked a little bit about this in your presentation about choosing ENT, but did you explore other specialties?
Oh, goodness.
Or yeah, before going into ENT, and what was really the motivating drive that made you decide?
So let's see. I went into medical school thinking I was going to do pediatric cancer. And then I thought I was going to do liver disease because my grandparents both had liver disease. And then I thought I was going to do radiation oncology. And then I realized I don't like physics, so that didn't work for me. And then I thought I was going to do neurosurgery. And I realized that lifestyle was a little bit more than what I wanted. Surgeon lifestyle is going to be difficult. Not to take away from my colleagues in other fields, I did mention I'm married to an anesthesiologist. Our lifestyles in surgery are different. They are more challenging. Those patients are ours. We don't hand off the patient at the end of the day. So if something happens to my patient at 2 a.m, yes, I have a colleague on call in a real pinch, but that's still my patient because I operate on them, right? So you're kind of on 24/7. That's tough. And so neurosurgery for me was just a little bit more than I kind of thought I wanted. I thought orthopedics looked really cool. But then actually when I saw broken bones, it kind of made me a little bit squeamish. So I actually realized that wasn't for me. I really, really loved cardiology. And to this day, I really still love cardiology. Probably could have done it, but internal medicine wasn't really for me. I really wanted to do more hands-on, more surgical kind of things. So interventional cardiology would have been great, but I would have to get through medicine, general cardiology, and then interventional cardiology. So that's what I mean. Like very, very few people go into medicine truly doing what they thought they were going to do at the beginning. Some people will, right? My uncle had this condition, so this is what I'm going to do. I get it. Some people, are that dedicated, and that's great. But I think when you go to medical school or nursing school or vet school, you want to learn everything. You want to learn about everything, and then eventually you focus on the things that spoke to you. And in my case, surgery was what I wanted to do. And once I got into that situation, where I was rounding on patients, where I was involved in surgeries with the faculty, there was no question that's what I wanted to do.
Thank you. No, I think it explains a lot, especially seeing the different specialties that you were interested in. Because I think a lot of us come in like not sure or having interest. So it's nice to hear that from the other side. And then talking a little bit about ENT and like it being surgical specialty with a busy life, how is the work-life balance like as ENT, and how do you kind of manage like your family while also being a physician?
Yeah, obviously, it's very important to have a supportive family, and then you have to communicate with them to not abuse that support. So if you tell them that you're going to be somewhere or you're going to do something, you really have to do your darnest to be there. Now, let's say there's a birthday party that for my well, I'm going to a birthday party for my father-in-law here shortly. Not today, but next week. And I better not miss that unless a patient is literally dying and it's my patient. If that's happening, of course, there's that understanding, but it can't just be like, oh yeah, do you really mind if I, go take something that's not actually something I have to take care of? So you have to communicate with people and you have to, stick to your word. You have to have someone who's willing to understand that this medical journey isn't about one person, it's about your family. And so, because everyone sacrifices, everyone around you sacrifices. And so you have to be understanding of that too. And sometimes you have to back off a little bit. We get paid for doing surgery or for seeing patients, right? Whether you're a family doctor seeing patients or whether you're a surgeon seeing patients, you get paid for that. And so you can always try to see one more patient, or you can always try to take care of one more patient. If you're a nurse, we got such a shortage of nurses. You always can do that extra overtime shift. You can always do 2 extra overtime shifts. And you have to, at some point, be true to yourself and realize, I don't have to do that, right? That doesn't, it can't always be me doing it. Sometimes you have to step up and help your colleagues, no question. If your colleagues need you in a bind, their kids in the hospital or whatever, I really hope you'll be the type of person who will step up and help. At the same time, it can't be every time they've got a birthday party to go to, which isn't urgent, that you step in. That's not right either. You have to think about your own people in your life, whether it's your friends, family, whatnot. So yeah, you get to choose as a surgeon and as a doctor and as a healthcare provider, how you're going to find that balance. If you're a nurse and you realize that or a pharmacist, my friend did night shifts for 2 years as a pharmacist. And he realized, once his kids started going to school, it wasn't making sense. It wasn't working anymore. So he makes a lot less money doing the day shift than he used to doing night shift. But you have to do what makes the most sense. He had to realize he had to give up a little bit of money in order to be there for his family. Every single one of us has to make that decision to try to balance better. It'll never be perfect, especially if you're a doctor, and especially if you're a surgeon, but you do the best you can.
Thank you. And for someone who is considering to apply for ENT residency, how can that applicant be a competitive applicant?
Yeah. That's tough. I should say that ENT was the most difficult match the last 3 years in a row. Harder than dermatology, harder than neurosurgery, harder than orthopedics, statistically speaking. And so, how do you do that? the USMLE, which is the first board score, got thrown out about 2 years ago. There's no longer a board score for the first part of the test. And some people heralded that as a success. They said, all right, we're just, pass or fail. But the problem is when you do that, how do you determine, where someone is, what their education is like and whatnot? So it becomes all the more important that your grades are good. And I've always been a person, when I look at applicants, I'm always looking for good grades because it shows consistency, right? You can have one bad day and have a bad board score, or one really good day and have a good board score. Now that board score is thrown out, now it's 100% going on you being consistent as a student, right? So you getting, commendables and every school has different grading systems, but you shouldn't just be passing everything, right? You really need to be demonstrating that you go the extra mile when you're on the wards, when you're in the classroom, that you are truly of a higher level. If you can, get involved in research. Now, it doesn't really matter what research you have. I did not have any ear, nose, and throat research when I went into apply, but I did have research because we know that you may have thought you were going to do orthopedics and then you change your mind and you want to do ENT, and that's fine. But try to get involved in research, get mentors who can guide you, and get good grades. Those are the 3 things that, unfortunately, without those, it's going to be an uphill battle for you, especially again, since we have been the most difficult to match the last 3 years.
Out of curiosity, is there a reason why ENT has been a difficult part matching?
No, ENT has always been very competitive for the last 30 years. Believe it or not, about 6 years ago, it got really easy for like 2 years or 3 years, where it was super, super easy to get in. And then I don't know what happened for those 3 years. I was actually the program director at the time, and then it flipped again. It became really, really hard, and then it became the hardest. So it doesn't really matter, though. I think how many people in this call are going to become ENTs? Very few. I think my point is really work hard to learn as much as you possibly can and to do as well as you can in your schoolwork and be consistent, right? Don't get honors in one because you said, this is what I'm going to do. And then the next one you say, I'm not going to do that. And you get the lowest score. I never thought I was going to be a psychiatrist, but it was actually my highest test score. I got 98 on that. All right. It's important that you go into everything with the idea this could be what I'm going to do the rest of my life. And, a lot of medicines that I prescribe today interact with psychiatry medicines or psych medicines. So it's actually really good that I had that background. So whether you go into nursing or physical therapy or whatever, learn everything you possibly can because it's going to play a part in your career at some point.
Thank you. And then for one last question to wrap up, you talked about research. And so is there any advice you have for people who are interested in similar research you're doing or like getting involved in research, also in med school, so expanding out, advice on navigating that?
Yeah. Find what you want to do. Find an area that you're interested in. Let's say you're interested in brain tumors. Okay, well, then now you need to look at your institution or your location. So for example, I'm at UT Health San Antonio, but we have UT San Antonio, University of Texas San Antonio. It's a different institution, but it's just up the road. Look at who's in your area. We have other universities in this area, Incarnate Word, whatever it may be, and find people in your region that have research in that area or something sort of related. And then at that point, you just kind of cold call. Hector Wong, who I owe so much of my career to, that was a cold call. I basically looked up people doing research in Cincinnati, Ohio, where I'm from, and I probably cold called a dozen or more people. And he was the one who gave me a chance. And boy, oh boy, did he give me a chance. But he gave me more than a chance. But, we get lucky sometimes, but we have to go out there and look for our luck. It doesn't come to us. If you're sitting around and you're, in your study and you're like, man, no one's coming to me for research. It's never going to happen, right? You have to go out and get it. And talk to your counselors, your pre-med counselors. You may have some good pre-med counselors when you're in medical school. Talk to your counselors there and say, I'm really interested in, cardiology, are there faculty members that are doing cardiology research that I can get involved with? And they'll try to get you in touch with someone in that division or in that department that can help you out. So yeah, you have to go out there and get it. Nothing's coming right to you.
Thank you, Dr. Chen. I think that's it for Q&A, and thank you so much for sharing a very detailed presentation and also like showing the animation. I think we all really liked that. But yes, thank you so much for spending a Sunday with us and sharing your insight.
Absolutely. Thank you for having me. And again, to everybody, good luck in your careers. It's a long career, but it's a rewarding career. I can't see myself doing anything else in this world. I mean, and that's the type of people we need in medicine who are going to be dedicated, because yeah, there will be challenges, but you're stronger than those challenges, and you'll overcome.
Thank you. And then for everyone else, we will be heading towards a break before convening back at 1 o'clock for our next HBSA situational test.
All right. Take care, y'all.
Thank you, Dr. Chen.